Good afternoon. Welcome. Welcome back for this week's lecture in the 43rd Annual Interdisciplinary MacLean Center for Clinical and Medical Ethics Lecture Series. I think I recognize almost everyone here and has been here once before. The theme of this year's series is Advocacy in Healthcare and Medicine. And we are delighted to have Dr. Krishnamoorthi with us today and speaking. Next week, so before I introduce Ram, next week, our own Harold Pollack, MacLean Faculty Center member, SSA faculty member, health policy expert, will be giving the talk at the same time. For those of you, I think probably most people here are on the MacLean Center list, but anybody wanting to be on the MacLean Center list for announcements of the new lecture series and the fellowship and other events that we sponsor, Lee View is in the back, and you can let him know. I'd give your email, but I think I don't know your email off the top of my head. Like, he can add you to the list, so communicate with him and get on the list. Today we're having Dr. Krishnamoorthi. So Dr. Krishnamoorthi is assistant professor of medicine at the Pritzker School of Medicine and in the section of hospital medicine. He is an internal medicine physician in the comprehensive care physician program, specializing in both the primary care and hospital care of medically and socially complex Medicare recipients at high risk for hospitalization. At Pritzker, he co-directs a course for entry medical students called The Foundations of Health Policy and the U.S. Healthcare System. He has been active in healthcare advocacy with Doctors for America, a grassroots organization of physicians and med students who advocate for comprehensive healthcare reform. He trains and mentors medical students in healthcare advocacy, including giving workshops on op-ed writing both here and nationally. Previous to being a faculty member at the University of Chicago, he served at the Hines VA, and he completed medical school and a master's in public health at Northwestern Feinberg School of Medicine and internal medicine training at Loyola University Medical Center. In addition to all of that, he is a fantastic colleague and an even better human being. Ram, we're really excited to have you, so thank you for speaking.
Thank you. I think we're on, right? Great. Well, thank you for the introduction, and thank you very much for inviting me, Dr. Pratt. It's a daunting task to see your name among so many other great works of bioethics and policy, and following those footsteps is tough, but we'll try. The reason why I'm here is to talk about something that I've been passionate about and have engaged in more so in the last several years here at Pritzker. Coming out of also the position of not just being a physician in a sort of health policy related clinical program, but also in being lucky enough to have a health policy course kind of fall into my lap, and then what has evolved from there. And that's advocacy training in medical education. So just a kind of a brief outline, we might actually bounce around some of these topics a little bit more, but just kind of overview of the growing interest in physician advocacy, and maybe not as much growing engagement. The growing interest in advocacy engagement by medical students and trainees. And kind of throughout, we'll be talking a little bit about the pros or the reasons why medical students and other trainee graduate medical students should be engaged in advocacy. And then also some of the cons and some of the drawbacks and disadvantages that I'd actually like to get your all's input on, so we can have a discussion about that. We'll talk a little bit as an example of some of the advocacy skills training that we've been doing here at Pritzker, some things that we're proud about. And how that kind of plays into that question about, should students and not, people who have not graduated from medical school or not graduated from their training yet, engage in advocacy about a healthcare system that they don't yet work in, right? And how they establish their authority or how they gain credibility, and some lessons learned about how we can guide people towards advocacy training in medical school. So there's been a growing interest in physician advocacy. I ran a PubMed search of the literature about what's just written about physician advocacy. Of course, that does not represent actually the activities, but it does kind of represent the observation of this trend. PubMed searches back in 1972. Right here in 2012, there are about 119 articles that had, physician advocacy in the title or in the subject area. And it really, really booms. It triples, more than triples. In 2024, there are 380 articles written about physician advocacy. Here are some of them. Achieving physician competency in advocacy. So that's very directly related to training. An argument for physician advocacy, the importance of it. Okay. Using medical training to improve systems. And then an issue-specific article about abortion advocacy, abortion rights advocacy. So the other interesting thing here is that the first article is written in a general internal medicine journal, and that one actually caters a lot to primary care and a little bit to hospital care, so a generalist model. Traditionally, it's thought that providers who are in primary care and general internal medicine are best positioned and most engaged in advocacy, not just for their patients, but also outside their clinical walls and in the system. But you can see here a number of specialists, specialty journals and specialists in the journals have been writing the Allergy and Asthma Society, for example, the transplant journal. And then this one, of course, is about abortion rights advocacy in a reproductive health care journal. And I think that speaks to a couple different trends that we're seeing in the engagement in advocacy and also in our training of advocacy for medical students. The kind of generalist approach and also some issue-specific approach. We'll talk about that. A lot has been happening during that period of time, that 10 to 12 years. We've had elections. We all know that elections have consequences. We had an entire pandemic that really brought to fore healthcare professionals and their expertise and whether or not we should listen to them. And I shouldn't have to say whether or not, but apparently the country has questioned whether or not they should listen to a healthcare system and health professionals about, a pandemic, about a new virus. A number of acts, it's nothing new, of course, but for some reason, certain acts of racialized violence have spurred even more advocacy, not just overall, but also among the healthcare community, thinking that healthcare providers have something to say about that problem, along with gun violence. One of our colleagues in Dr. Krishnamoorthi was a trauma surgeon who actually was a victim of gun violence as well. And when, after one of a number of mass shootings, he spoke up on social media about how we need to treat gun violence as a public health problem. Well, the National Rifle Association and gun rights advocates didn't like that, and they told him to stay in his lane. And this was a grand opportunity for him and our colleagues to launch the This Is My Lane campaign. The trends in the healthcare system and physician practice. These are some issue-specific topics, but this one is specific or general to the healthcare system. We'll talk about that. Note that in this last 10 years, for our current medical students and current graduate medical trainees or residents, these are the formative years. They're in their adolescence or teenage years. Many are in college at this time, and they haven't jumped into the system, or they haven't had to face reality of practicing medicine yet. So this time, where there's been an increase in the presence of advocacy as an activity by healthcare professionals, seems normalized for our people who are training right now. Okay? But there are barriers to practicing physicians to engage in advocacy. We'll contrast that with our students and learners. In a 2006 survey, way back when, before all that trend for the last 10 to 15 years, 90% of physicians actually agreed that advocacy should be an important part of their physician practice and career. But it's possible that they're thinking of different things. We all have known advocacy for our patients, patient advocacy, to be an important part of our clinical work. And what that means is advocating to make sure that our patients get the right care at the right time in the right setting, that we make those extra phone calls, that we do the extra work to get their medical equipment, and we work with other disciplines to get our patients what they need in a system that sometimes makes it very difficult to get them the right care. But Health policy and political advocacy activity, only 25% reported that they actually engaged. Fast forward to another survey of University of Wisconsin physicians, and only about 15% of their activities met the division of being highly engaged in advocacy. Highly engaged means engaging even in one activity that took a little extra effort outside of clinical hours that was directly impacting the healthcare system and healthcare policy, not just patient advocacy. And here are some of the quotes that the authors pulled out about why there wasn't more highly engaged advocacy. Those not highly engaged were more likely to report, I don't know how to get involved. There's a difference in having health policy advocacy training. Highly engaged people, about 50% of them had actually had some formal training. Less than 20% of those who were not engaged reported that they had some training. So training is an important aspect of the barriers of why practicing physicians don't get involved. Time is another one, the lack of time. So those are those two common themes. Physicians, however, have been involved in grassroots advocacy and also in organized medicine for many, for a whole century, or even more. But there's a big difference, we note, between the grassroots advocacy of individual of practitioners and organized medicine. Physicians have advocated for national health insurance early in the 20th century, opposed by the American Medical Association or organized medicine. Inclusion of underrepresented people in medical school, opposed by the American Medical Association early in the century. Physicians for a national health plan for single payer, late into the 20th century and 21st century, continues to be opposed by the American Medical Association. There's been a slight progress about that. Whereas organized medicine's agenda has mostly been about topics of medical malpractice reform, preserving payments in the physician fee schedule, which, by the way, was created by the AMA, opposing the expansion of the scope of practice of nurse practitioners and PAs, fighting insurance abuses, and supporting private practice and fighting consolidation and private equity and the financialization of healthcare. The theme here is mostly the self-interest of physicians and organizations. And not that there's anything wrong with that, but organized medicine has mostly represented its own, somewhat like a union, and less so about the system that affects the patients that we provide care for. If you look at medical student advocacy, also a very long history. There's a brilliant article really nicely summarizing how much medical students have had an impact. In the 20th century, the early 20th century, the Association for Interns with an E and Medical Students was supporting national health insurance, squashed by the AMA and some anti-communist sentiment. In the 70s, the AMA Medical Students Association actually was instrumental in getting smoking bans on airplanes, which then led to smoking bans in public places. The AMSA also broke off from the AMA because it had a stronger stance on civil rights. And AMSA, the American Medical Students Association, was also instrumental in promoting wellness and reducing excessive workloads and improving safety, and instituting work hours in 2002, directly having an effect on policy. Okay, this is institutional policy, not necessarily, but also legislative policy as well. So students' lenses of the healthcare system are much more their lens about society, about health equity, and specific issues related to health equity, specific populations related to health equity, and specific types of care. So students in these formative years, in these last 15 years, have continued to look at the events of our society, acts of racialized violence, structural racism, structural inequities, gender bias, et cetera, against specific populations, and found that they feel it's normal. And it's, of course, it's an obvious, the answer is obviously yes, that physicians, medical professionals should be involved in advocacy, because we have to fix the problems of society that are directly related to health. So in this lecture series, you probably heard a lot of debate about that. To these students and these learners, there's no debate. It's a decided question. what kind of advocacy activities do students and physicians actually do? Organizing with other groups or among themselves to collaborate, educating each other about those issues, about the specifics, bringing awareness to them, and a number of other ways. Anything as easy as signing a petition, to organizing and sending rallies, to op-ed writing, which we'll talk about in our what we're doing here at Pritzker. So, in response to a bunch of these trends, the trends of these events over the last 15 years, a feeling of empowerment by physicians, a feeling of responsibility by physicians to engage in advocacy in the system outside the wall, and also in response to what students want, what learners want, there has been a growth in advocacy in medical school curricula across the country. An article in 2021, one of the co-authors is the dean of our medical school, Vineet Arora, found that most medical schools do offer courses that have some elements of advocacy in them. And this was an increase from prior years. There really wasn't much of a systematic review of this topic at all before that. The thing is that talking about advocacy is not the same thing as teaching the skills of advocacy. And advocacy skills training actually was almost all elective courses. And those advocacy skills were only learned or were only taught to a minority of the students. Here's a few examples of some that I've learned about. At New York University, there's a 4-week health policy course that's an elective, mostly didactics, but also some practical skills training, culminating in a legislative advocacy trip, and also in the skill of writing a position paper as being an advocate on a particular stance on a particular issue. But not just medical students, but also residents. And Duke Internal Medicine residency has this quarter-long course on policy and advocacy skills. Note that there's a coupling of talking about health policy, about the current status quo of why things are the way they are, and advocacy. That's an important coupling that we'll also chat about. And they culminated also in a lobbying trip to DC. Here at Pritzker, we have a number of courses that are both required and elective that have elements of advocacy and advocacy skill and practical training in them. We have a course that used to be called Health Disparities, and I think the transitions in some of the naming is also telling. It transitioned to the name of Health Equity, Advocacy, and Anti-Racism. Here is how it's abbreviated. I renamed the American healthcare system to the Foundations of Health Policy in the U.S. Healthcare System. Actually, and specifically, wanting to talk about how health policy as an avenue of advocacy, but not just what it is, but how health policy made, not just how the healthcare system works, but how did it get this way, and where someone can engage and influence. Within this system, about 3 years ago, we embedded an op-ed writing, practical exercise. Now, the exercise was required of all the students, but the exercise did not have to be that they have to write an op-ed. They have to write something about a topic of their choice in their final writing assignment. But over half of the students chose to write it in the format of an op-ed. Why op-ed writing? The pandemic saw that we had to, close ourselves behind within indoors, but we saw this pandemic happening, and we felt that we had words to say, despite others telling us to stay in our lane. Writing is accessible. Most medical professionals have writing skills. They also know how to research topic and do persuasion, and it's actually a clinical skill, identifying a problem and thinking about solutions to that problem, and looking for the evidence and objective data to support that. You can do it on your time, you can do it collaboratively. It's effective, but even if it's not effective in changing policy, it messages to the public our values and our positions on it. But it's risky. Putting your words out there in publication and on print, for someone who's a seasoned veteran of a topic, who's an expert, maybe will recognize nationally or not, is willing maybe to take that risk. Students and learners are educated about that risk, so we counsel them about it, and they take that risk anyway. And that risk can be, first, having a stamp be attached to you for the rest of your life, and also the reputation that you earn from that when you're searching for new jobs, when you're searching for residency, for fellowship, and a job afterwards. And the presence of social media, of course, makes that most of your stances and positions on things quite searchable and findable. In our health policy course, I'll just briefly I'll tell you about this, so it motivates why advocacy is a part of it. We test after the health policy course, before and after, we do a knowledge quiz, and we find that clearly knowledge increase, and also something I'm proud of is that the confidence in health policy knowledge increase. This is on a Likert scale of 1 to 5, rate how confident you are in how the healthcare system works. The percentage of students who agreed that they would like to participate in health-related advocacy also increased. It started out very high. So students enter, like I said, they enter into medical school. These are first-year medical students already saying, like, yeah, of course I want to advocate. But there was a statistically significant increase for that little group of people who said that they didn't want to after learning about the healthcare system, learning about health policy and the structure of the system and its details actually empowers and engages more people into advocacy. So this embedded op-ed writing curriculum, it came out of students' feedback because they're so interested in advocacy that they want to choose their own topics and write in a persuasive way. And that relates to the nature of advocacy at the student level, issue-specific advocacy. Not the broad strokes or even the weeds of healthcare financing or policy that many of us practicing physicians complain about on a daily basis, but issues of equity and structural inequities. We held an op-ed writing workshop that was run by a faculty member, and then we had a system of peer coaching and editing. And the reason for that is that writing is an iterative process, and we just don't have enough faculty members to actually mentor and engage in the revision and editing of 90 plus or 45 to 50 plus op-ed writing samples. So we created sort of a peer system where their own classmates would edit, and then they would come to faculty members if they're interested in submitting for publication. 42 op-eds were submitted to consider for publication. And this is over 2 years. I'm sorry. So among 180 students, 105 wrote op-eds, and 42 of them wanted to submit for publication. 22 of those pieces got published in external publication. Pretty much everyone, it's the first time for their publication that they've ever been published. And counting. This was data from 22 and 23. Here's a sample of some of the topics and publications that people wrote about. The triple-demic revealing, that's the flu, COVID, and RSV, revealing a broken childcare system because people had to stay at home and they didn't have adequate childcare to do their jobs and take care of their other job. Women's health issues in research. Over-the-counter naloxone, so making opioid use disorder treatment more accessible. Students have something to say about that. Denying access to incarcerated people's health care. Suicide and gun violence rising, and then protecting reproductive rights. Very issue-specific things. You don't see among this list how we need to change the RVU system and the physician fee schedule, or how we need to improve payment for quality initiatives in the hospital, things that a lot of practicing physicians are interested about. These are issues of equity and issues of specific health care that they feel are lacking. So why should learners engage in advocacy? So what is a pro or an advantage to it? Well, they want to do it and they do it already. I think we've demonstrated that. And surveys have already shown that they strongly, or at least agree or strongly agree that they should make it part of their career. But advocacy is a skill like any other, and it requires training. And some of the pitfalls or cons against maybe asking learners to engage in advocacy are the reason why we should train for people to do it properly and effectively and responsibly. They have more time, they can collaborate with practicing physicians and higher level trainees. Okay? And they have us an advantage over practicing physicians in this way. While the public views physicians very respectively, we still continue to be sort of a group of people that is not part of the public. That there is the public that goes to us for healthcare, and then there's us. Learners, especially entering medical students or preclinical students, they're on the cusp of those two aspects of society, in the public and the people above them. They've got a foot in the door of the public, but they also are viewed by the public as members of our profession. Whether seasoned professionals or not agree with that, the public sees television shows like ER and Chicago Med. I think this is the second reference to ER in a week, and nothing else. They see Noah Wiley, whatever his character's name was, cracking chests open and doing healthcare. So of course, they think that medical students are medical professionals. I agree. They have immediately leapt into the profession of medicine. Once they enter medical school, what does that mean? Medical students have the privilege to see things that other people in society don't have. Medical students, whether they know the details about medical care or not, are exposed to all the human condition in a way that the public is not. So medical students have this advantage of being both in the public and just coming from it and having the interests of equity and the issues that are important to society without being jaded to medicine that some of us will talk about and have. And they also are viewed by the public as responsible members of the profession. So as members of the profession, should they do what our professional societies say they should do? Despite the debates on whether physicians should engage in advocacy, the professional societies have already decided that it is a responsibility for physicians to engage in advocacy. Physicians must individually and collectively strive to reduce barriers without concern for the self-interest of the physician or the profession. It's the American work of internal medicine. Plenty of specialties also have similar statements. Advocate for strategies to improve public health in individuals. Our profession is accountable to our communities and society. You don't hear these kind of conversations in the physician lounges and in many community hospitals, but the physician societies don't disagree about that. Is advocacy training required in medical education? So in graduate medical education, we'll start with that first. There is a concept, there's a core competency called systems-based practice. So residency program directors are required by the ACGME to demonstrate that they are providing opportunities and training for their residents in systems-based practice. So what does that mean? We'll talk about that in 1 second, but it means that practicing in our healthcare system has its own unique skill, and that residents should learn how to do that, aside from just their clinical, medical, and surgical skills. But ACGME does not specifically require that advocacy be an approach to competency. It does name health policy advocacy as a highest fulfillment of systems-based practice on its rating scale. There's a rating scale where residency program directors evaluate residents, and on this core competency, at the very highest level, is this resident has engaged in health policy advocacy. But the ACGME doesn't require it. What about medical school or undergraduate medical education? The LCME is the one that accredits medical schools. According to Google, actually according to this article that Google found for me, the LCME has not explicitly mentioned advocacy or health policy training in its accreditation standard. And I point this out because this supercomputer went through the thousands of pages or whatever of medical school curricula and requirements and summarized. That was the very first line that it came up with. LCME just doesn't mention it as part of its requirements. And even further, medical schools are responsible themselves for deciding whether they want to include it in curriculum. And then it provides some suggestions. By the way, this article, I met the first person, no relation, and not even the stuff. I thought you were the author. I was trying to brag, but I spelled my name wrong. Are all our medical students. First year medical students when they wrote this article and then attending to provide. And this is an excellent summary of advocacy. So medical education formally doesn't require advocacy. And I think that they're being careful. I think they're being safe. And I think they're instead focusing on the core competency of like what a practicing physician should be. So originally, the systems-based practice competency focused on providing care in the context of the microsystem and the macro system, advocating for the patient. So how do you improve on the quality of what we already do, given the context of the constraints of our system, both our hospital system and also our larger healthcare system? And the ACGME clearly wants residence program directors to do that. So that's required of programs to engage in that kind of quality improvement, systems-based practice skills training. But this evolved to include thinking about the healthcare system. Pediatrics programs have actually required advocacy training. I should provide the exception. Pediatrics is the exception. They have required advocacy skills training since 2001. And every program has some opportunity and also requirement to demonstrate it. So a qualitative study of pediatrics programs demonstrates this evolution. Early on in the decade, projects were typically grounded in residents' personal experiences with families, patients, or even colleagues. They advocated in the context of the clinical or the educational setting. But later in that decade, residents took increased ownership of the title of advocate, and they did community-based work, and they related their work to health equity and health policy. So that advocacy role evolved out of the systems-based core competency, systems-based practice core competency, right? And evolved again over this past decade of 10 to 15 years, where somehow society has offered up to healthcare professionals that you have a role to be involved. And we've taken it up as not just an opportunity, but apparently also a responsibility. So another safe approach to this whole conversation is the idea of health system science. Health system science, or HSS, has now come to encompass also health policy. It started off mostly about quality improvement. How do we improve the system, and what is the system that we're trying to improve? But how do we improve it at a microscopic level? We work with interdisciplinary teams. We try to reduce medical errors. We try to improve the discharge planning process at the end of the hospital. We try to get people primary care appointments within the context of our fragmented healthcare system. But the health system science gurus also decided to include health policy in the larger and changing the larger healthcare system within its science. In my mind, this is a safe approach because it's still attaching the improvement of health policy and healthcare system to quality improvement. Does quality improvement equal advocacy for a better healthcare system? I would say no. The reason why is this. Quality improvement is shouldered as a burden by healthcare providers. The hospital and the physicians have a responsibility for improving the quality of the care that they do in the context of the whole healthcare system. Advocating for the healthcare system to change places the burden on policymakers, places the burden on society, on taxpayers, to take it upon ourselves as a collective group to change the healthcare system such that the quality of healthcare doesn't constantly require quality improvement projects. That difference in change and shifting of burden is important because it absolutely parallels the way that healthcare financing is in our healthcare system. We moved from paying for fee for service, for paying specific fees for the healthcare and medical care that we do, to paying for value. And paying for value is a healthcare system change, but continues to shoulder the burden of improving the healthcare system on the providers, not the policymakers. Okay? Much more complicated topic than that, and we could chat a little bit more. So why so safe? Well, there's broad agreement that physicians need to be educated better about the healthcare system, how it works, how financing and insurance do. You can't really talk about the healthcare system without talking about the policy that makes the healthcare system. However, you can talk about healthcare policy without talking about advocacy. Another safe approach to talking or teaching about healthcare policy. But I have found it in 10 and 11 years of teaching about healthcare policy, I have been hard pressed to talk to entering medical students, again, on the cusp of just leaving or being still part of the public and entering into the medical profession, how patients are not able to afford their meds or obtain equipment or come to the University of Chicago because it's not in their insurance network, why Medicare reimbursement rates are better than Medicaid, why there's a change in the industry and profit making in healthcare. I've been hard pressed to talk about these issues without someone asking, why is it this way and what can we do about it? Inevitably, learners want to know how to change it. Today's learners are not captive. They don't feel like they're captive. They don't feel like they need to be captive. So the debate on whether physicians should engage in advocacy from an ethical perspective is answered and also inadequate for these students. If you talk to me about how the weeds of how health policy works and how healthcare is financed, I'm going to ask you what I can do to make it better. That's what they say. Another argument, several arguments in favor of advocacy training in this respect, or because of that, is that political influence is happening anyway. I already talked about organized medicine and the agenda of the organized medicine and physician societies. Political influence is already happening by physicians. The organized medicine or professional societies send its members to Springfield, Illinois, or to Washington, D.C. to lobby against Medicare payment, to lobby against increasing the scope of practice for nurse practitioners. So physicians are doing that kind of political influence. But it's also happening to physicians. If you're not on, if you're not at the table, then you're on the menu. Your payments are going to get cut. Your scope of practice of other competing professionals is going to get increased. So political activity is already happening by physicians. Even if it's happening by professional and expert lobbying groups, physicians are the front-facing part of that lobby, not just the lobbying professionals. The healthcare industry is changing. The fact that the healthcare industry is changing affects trainees very differently. The options that trainees have in entering into their professional career are of a different sort than the options that when I came out of residency, the options that people came out of training 40 years ago. Again, fee-for-service medicine is trying to go by the wayside, and value-based payment is what they will be facing from the get-go. Physician in private practice and small group practices are giving way to large consolidated hospital systems that employ most physicians now. That's their automatic training. Because the healthcare industry is changing, advocacy for changing the healthcare industry takes a much, much higher priority than simply viewing them as quality improvement projects. Students and learners have time to do it, and they're positioned on the cusp, like we said. And then finally, as members of society on this cusp, they retain ideals. And here we are with the not so fun thing to talk about, which is idealism and the art of idealism, the reality to cynicism. Along the way, trainees, and I'm actually specifically just talking about trainees, let alone practicing physicians, face moral injury. This isn't what I signed up for. I didn't know that the healthcare system was like, I didn't know that this insurance network doesn't cover the care that I want to provide. I didn't know that I have to call pharmacies to find out whether this prescription is covered by your insurance or not. So moral injury is when the system injures those values that you come into and the reason why you signed up for medicine to help people in the first place. And that burns people out, it causes a mental exhaustion, it causes physical exhaustion because all of that extra work is exhausting and fatiguing. And it puts people up against this reality that there's a loss of agency about the healthcare system. A loss of feeling that what I do can be efficacious for patients because of forces that are outside of my clinical practice. And after that comes the bad one, and that is cynicism, where people don't feel like they can do anything to change the system, and that nobody is trying to do something to change the system, And even when it looks like people are trying to do something to change the system, they're out for themselves. And in many examples, in many cases, they're not wrong. But the problem is that cynicism now, if that wins, then we have a healthcare system that remains in the status quo. And we have a captive audience of a captive group of healthcare professionals that started off feeling not captive, feeling like they could solve the world's problems. That idealism is something that we should take advantage of. We cannot let that go. We can't say like, well, it's too soon. You don't know really what the healthcare system's like. Let's see when you have to, you get your paycheck. Let's see how much, goes toward taxes. Look at the Medicare tax that's come out. You want Medicare for all? Well, guess what? So we can't wait because we will lose this in this arc of going from idealism to the bad word. Okay. So I mentioned a few of these things already, but what are some of the cons? I've listed a few up here, but who can brainstorm some reasons that we shouldn't be training medical students? I probably made it right, but why we shouldn't be training medical students. I'd like to hear from all the generations of people that are here. Who thinks that students just don't know what it's like? Oh, I see your phone there. Hi.
I know that sometimes the argument is that like medical training is like clinical knowledge, and the more things you have that don't make you better at presentation and diagnosing patients, is like diagnosing the medical profession, like what the core point is.
Okay. It takes away from that clinical education time. Okay. Anybody else have thoughts about that?
My opinion, but when I was in med school, I
Yeah.
had a lot of classmates who regarded any moment spent on anything that was not going to be on step one.
Yeah. What's step one?
Yeah.
I think there's some. It's the
The big board exam, it was
Right.
pass fail now, but it wasn't pass fail at that time. And
Right.
so you would really do something for the pathology or anesthesiology or surgery.
Right.
And so it meant that there was like this, like we had required help providing classes.
Yeah.
And there was a lot of editing from.
Yeah.
I think number 3 is always been the one I can probably based on my training. The concern that you both disrupt the potential for a doctor-patient relationship, where you come to believe that your views supersede that of taking care of a patient who might have different views than you.
Got it. Yep. Yeah, in the same morning that you read an op-ed by your primary care doctor and you go to see him that afternoon for a visit, things have changed the way you do it. Okay.
I'd say combine 3 and 4 kind of thinking as a career advisor for medical students, because otherwise it's for a short-term reputation.
Okay.
That if this is, if you write an op-ed, it's published out there,
Yep.
this is now your sort of the platform that you're standing on, and a medical student who has applied for residency, that you'll be applying to programs and people which that their stance may be viewed negatively.
I'll go ahead and say that in the last year, a couple of years last year, the risks that you're talking about have gone from different stances about abortion rights, different stances about who should get paid more, things like that, salary differences, to other things that are really get into identity and possible accusations of racism. The war in the Middle East. Many students were quite passionate on one side or the other, and we've had to counsel them about those risks.
Yeah, I'm not a clinician then, so you just brought up one of my concerns, but I take your presentation to be talking mostly about, and I could be wrong, advocacy in the healthcare system, but I worry when that expands beyond that to
Yeah.
what you're speaking about. Areas of expertise that perhaps not just a medical student, but a physician may not have a depth of experience or term knowledge, but have a passionate view about. And so, like, I think one of the thoughts is how far we should the advocacy be, maybe?
Yeah, yeah, and so the philosophy, one philosophy that has grown in this whole topic is healthcare affects everything. Health is in all things, and therefore all things and all policy affects health. And that is a reason stated for why everything is their lane. Rachel?
The undertone problem, though, really is probably from like the polarization of politics. Like if things were not so black and white in politics, we would really be having this conversation about how advocacy affects your, how you're seen in public, et cetera.
Yeah.
I think that if things weren't so, I'm either a Democrat or a Republican.
Right.
These are my core beliefs, and I will not stray, and I will not, and the other side is bad.
Right. Yeah.
They have that. I don't think
Yeah.
this is a conversation.
Many students, physicians who engage in advocacy for just the right thing believe it's just the right thing. There's objective data about it. There's safety and there's health concerns where there's facts that support what I'm trying to pursue. Why won't you just, agree with me?
I actually disagree a little bit. I think that for a long time, people who have run residency programs in hospitals, not people who are so reliable. And what they mean by that is they want to be sure that they're called people whether they're not disruptive at all. I'm not saying I agree with it. But for a long time, this was the argument, that was effective. It's like, well, why would I get the female when she made that pregnant? Yeah, we should have a call table. And the big thing is, whether I agree with the patient for resident political meetings or not, the fact that they're out there being non-neutral is enough to say this person is more problematic than someone who is neutral. There will be neutrality to that.
The neutrality is that for doing their job.
I mean, neutrality on the system from the program director perspective, or from the training perspective, or from the system, or even from the employer perspective. I think that maybe academic centers maybe slightly different, but certainly private healthcare institutions do not want somebody who's out there who's writing about advocacy. They want somebody, I don't really know about
Yeah, I find that to be somewhat aligned, I think, with the previous comment, because if an atmosphere that's not polarized, then that wouldn't be as explosive a response to the system. How are you employing this activist?
That's my question. Look at
Yeah.
Neutral or not.
In Canada, there are a number of advocacy skills training curricula at both the undergraduate and graduate medical education level. And we all think Canada is perfect, so. What do they need to change? Well, last one I'm gonna move on. People, or actually, the person with.
Okay, I think adding on what they are saying, in my mind, I think that the risk would be in the opposite direction of like, when you are justifying the importance of student advocacy, you are using examples on how the student medical association was like could achieve something because they were more independent and more daring. So my concern would be if you structure this advocacy position too much, that they would be too cycling them to like oriented in a specific way and not like.
Yeah, okay, no, I understood. So let's look at a few examples from our curriculum of advocacy projects, and then some op-eds that have been written. So Nikita Deshpande, sorry for the blurriness. Nikita Deshpande and Alan Hutchinson. Nikita is going to be a chief resident in internal medicine. It sounds like she's a pretty good doctor. And Alan Hutchinson, I think, is doing advanced therapeutics and gastroenterology. at the University of Chicago. It sounds like it's pretty good doctor. They joined forces with other organizations doing this to fight for these, a law to make medication repositories legal and encouraged in Illinois. All that is that when people waste medications, generally policies and laws do not allow those medications to be used by anybody else than another person that they prescribe. And some people think that this is ridiculous. There's a loss of very expensive medication that people cannot afford. And medication repositories have been tried, and Illinois was able to achieve that after a huge advocacy effort, not just from them, and they wouldn't say that, but 2 doctors wrote an op-ed, and then we joined with other organizations, and the next year, Governor Pritzker signed the law for this medication repository system. That was the agony. These are a group of medical students who learned about the Dickey Amendment. Who knows what the Dickey Amendment was? The Dickey Amendment was enacted in the 90s as a law that basically said that no federal research funding can go towards research that directly advocates for gun control. And those are roughly about the language of the rules. So most researchers of public health and violence were chilled at actually doing this work and obtaining federal funding for it because they thought that they would be sanctioned, they'd lose their funding overall, even though they all believed that gun violence was a public health problem. So these students and a nationwide movement that have been working wrote op-eds, and they visited the presidents of the University of Chicago a number of times, apparently. I think they just nagged them to look in the face of this policy that the University of Chicago has, which is the Calvin policy. Calvin, yeah, the Calvin principle, which is that as members of our university, we do not make political statements as an institution. You're free to have free speech all you want, but we're not changing any of our policies to support one political position or other. And they said, wait a minute, this isn't a political position. This is about research. This is about truth, facts, honest, funding of finding out and discovering the truth. And the University of Chicago, I don't know if it's just after them, I don't think it is, but certainly they got a letter from the university president saying, thank you for this, we're going to change our policy. We are going to support an end to that Dickey Amendment. The next year, a law was passed on Congress repealing that amendment. So let's look at some op-eds. You can read a few of these op-eds. I'm going to just interest some time. I can come back to this QR code. But what are the topics that my first year medical students wrote about? And let's test some of the cons, the disadvantages, the concerns that some people have raised about that. Socorro Turner wrote and got published in the Chicago Tribune an op-ed about decreasing breast cancer mortality for Black women. Tony Liu wrote about increasing funding of care for adolescent mental health so that it may increase access. Hassan Asif wrote a part, reviewed for people the Inflation Reduction Act's provisions, closely factual, but he incorporated his personal story about how his EpiPen skyrocketed in price. And I think some members of the audience have experience with that. And Anna Thorndike got Newsweek published an article about improving funding for healthcare on House. So are any of these topics that controversial? They're disagreement for sure. People disagree about that. Are they the kind of things that tell people to stay in their lane? I don't know. I mean, you can test it out. I think you could probably wonder if a program director would be embarrassed by a student in there, a resident in there writing this stuff. Maybe the Inflation Reduction Act is a Biden proposal, and we really don't want to be pro-Biden in our residency program. I'm not sure. Lahiri wrote about the triple-demic of RSV. What gives her any authority or any credibility to write this? All she did was she shadowed at a pediatric clinic and she observed some things. Again, at the cusp of the public, but having the privilege to see things that the public can't see. Christian Carrier, I think, did a very bold thing, which was he wrote an op-ed about ending the ban on blood donation by men who've had sexual contact with men, a ban that goes way back to the years of HIV. And he talked about himself as a gay man and how disappointed he was that he could not donate blood right during the pandemic when we were facing a blood shortage, right? There was pertinence to the problem. There was a personal contribution he had to the problem. There was objective research he had. Bringing those together, he wrote an op-ed that I think was helpful. He was invited by news outlets to talk about this. He was invited to a national panel also to talk about this. Did he overstep? I don't think so. I'm not sure. Tatum Call has written now like 3 op-eds about women's health issues. Alexander Bean wrote about how binary medicine and referring to people in a binary way is injurious to our gender expansive patients. Now, what she did was she used what we call in op-ed writing a to be sure statement, where you address the counter arguments and you acknowledge that those counter arguments are reasonable. She did not address the anti-LGBT comments that she got after writing this op-ed. Instead, she addressed concerns by medical professionals that there's not enough time to learn and to get trained in using more gender expansive language to take care of patients. And she addressed that by pointing out a number of comprehensive guides. Did she overstep? I'm not sure. Is it embarrassing? Not for me. So some of these articles to me just represent the advantages, the time, the opportunities, and the personal contributions where people are positioned in their lives, both as being just regular people and having this, stepping into this privilege of becoming part of the medical profession. And so going forward, what I think I've found is that the way to properly train in advocacy and to mentor students in advocacy is to guide them in a structured format. There has to be ample time and space for this work and for the mentorship. It cannot be, we cannot continue to depend on people using their extracurricular hours. We need to promote researching the topic. People have to get their facts down, not just the actual inequity outcomes, but what are the specific structures and policies that give rise to those inequities? You have to get into the weeds of policy making. It's super boring and it's annoying and it's frustrating, but you have to get into it so you can know how it came about and how things can change. And that is definitely a gap that I've noticed in op-eds that get published versus ones that don't. What are the other organizations and experts saying? You are not alone in this. You're not the first person to notice this. Advocacy is a team sport. Partnering with practicing physicians so that your credibility about clinical topics is fact-checked and checked by clinicians and edited. That's the most important. This is specific, especially to op-ed writing, but it can apply to other advocacy activities as well. I think that advocacy training and medical education may not necessarily be required, but is beneficial. And it's beneficial because advocacy is a skill like any other. And if it's done without that training, the risks that we're worried about learners getting involved in advocacy are more likely to happen. And the benefits of having an entire population of idealistic, young, early medical professionals in advocacy, I think is an opportunity we shouldn't miss. Thank you very much.